on the faculty, and in private practice here in St. Louis, it's a Ladue area in the common country area. I'm going to talk to you today about allergies and what you need to know.
Thank you, Matt. Well, it's an honor to be here this afternoon. When I first started to go into allergy so many years ago, one of the things that attracted me most was that there was such a huge number of patients hospitalized in my training program with asthma. And I thought that there must have been a great need for physicians to take care of all these patients. And that was before I knew to what extent allergies played a role in their asthma, and it was also before I knew how serious the allergy issues are in the St. Louis area, which those of you who have allergies can certainly attest to. And so the other thing that I have loved so much about practicing allergy is its fundamental investigative nature. If someone has a problem or a reaction or any kind of clinical symptom, I get to try to figure out what caused it. And I think it's not only very, very satisfying to the patient and to me, but it also can be very useful. So I did get to take care of lots of patients with asthma and explore many other allergic abnormalities as well. And then I also got to witness firsthand the tremendous rise in food allergies, in particular peanut allergies. And so in 2016, it's especially exciting because I think there have been some major breakthroughs in understanding why that epidemic may have occurred and what we might be able to do to prevent it. So I thought what we would do is talk about some of the basics of allergies. What are they? What are the signs of symptoms? And what is the science behind it? What makes a person actually allergic compared to somebody else? And then we would talk about some of the why questions. Why do we have allergies? Why do allergies seem to be increasing so much? Why has there been an asthma epidemic? And why has there been a food allergy epidemic? And in looking at that, we'll look at some of the prevalence issues, the hygiene hypothesis, and feeding trends. And finally, how to manage allergies, how to diagnose them, what strategies can be used to manage them, and then a final word about prevention. So what is an allergy? I think everybody thinks they know if they have an aversion to something or if they've had a reaction to something, but not every intolerance is an allergy. But broadly defined, allergy is some damaging or harmful immune response to something that's normally harmless because of the state of being hypersensitive. So this may be too much information, but I think it's worth trying to look at a little bit of immunology. The immune system does a number of things, but one of the things that it does is produce antibodies. And in this particular picture, those Y-shaped, in actuality, very large macromolecules called immunoglobulins are stuck firmly to this target, which is actually a cancer cell in this picture. And what will happen is by virtue of those antibodies stuck to that target will be eliminated by the body. It'll be taken out by certain cells in the spleen and the liver, and it will disappear. And so that will have been a successful immune response. These antibodies are highly specific. They're for the target or the target protein. And the most common one in the bloodstream is immunoglobulin G, or IgG. Now, in allergic individuals, there are antibodies also very specifically directed against normally harmless substances such as pollen and dander. And this is called IgE. And it has some distinct properties that distinguish it from the immunoglobulin G system, or the normal antibody system. And this is the last of the major science slides. But if you look at if you look at the cell at the bottom that has the Y-shaped antibodies stuck to it, that is a mast cell or an allergy cell. And it is essentially loaded with those little white circles that actually contain preformed chemicals and also some newly formed ones when the allergy cell or the mast cell is activated. So those IgE antibodies that are stuck to the cell are ready and waiting to react to the next pollen grain or mold spore that cell sees. And when that happens, a veritable explosion will happen where all these chemical mediators will be released into the local environment and will cause the symptoms of allergy. So the three components of an allergic reaction would be the IgE antibody, which is highly specific for whichever pollen or mold or drug or whatever it is, the mast cells, and then the different triggers. And some of the triggers are varied: pollens, molds, animal danders, dust mites, and then a number of different foods. And the foods that are triggered tend to be large molecules, they call them glycoproteins, which fool the immune system into thinking that they're microbial targets, like they look like an organism the immune system should react to. Stinging insect venoms cause particularly dangerous type of allergy in some individuals. Medications cause allergies, and a word about that is that it's not usually, or it can be if it's a large molecular medication, but a lot of medications such as penicillin, the immune system cannot see a tiny molecule like penicillin, but the penicillin becomes metabolized and it gets stuck onto body proteins that are then large enough that the immune system sees. But it makes it difficult to test for drug allergies because if you test for the drug in its native form and you get a negative, it won't mean that you're not allergic. And then there are other interesting things that people are allergic to, such as latex, seminal fluid. The list is quite large. And then this shows an exploded mast cell, and these are chemicals, it's a cartoon of it, with chemicals floating around the environment. And histamine is one, and leukotriene is one, and then there's many other ones that recruit cells, cause inflammation, and cause all the signs and symptoms of allergies. And here is a typical type of symptom that occurs in the nose and the eyes. Those chemicals will cause sneezing, itchy eyes. It'll cause the nose to produce quite a bit of mucus in a typical hay fever type reaction. On the skin, if the mast cell reaction happens in the superficial skin and the epidermis, you'll get hives. If it happens deeper in the skin, you'll get swelling. And so the top picture is a picture of some child with hives, which are raised welt type rashes. And then the lower is the swelling in the lips. And they're very similar reactions, but one tends to be a little bit more alarming than the other. And also you get flushing and you can get a lot of itching. Another cause, effect of those chemicals have to do with the airways in the lungs. And as a result of inflammation that's caused by these chemical mediators, one gets coughing, wheezing, chest tightness, which is characteristic of asthma. And I'll spend a moment defining asthma so everyone's on the same page about asthma. It's defined as a chronic lung disease that is characterized by inflamed and narrowed airways. And you can see a picture in the lower part of airways. The left is normal, the right is inflamed, and it's swollen. There's additional inflammatory cells in the lining. That airway is more narrow, and also the inflamed airway is much more likely to have bronchoconstriction, which is when the smooth muscle that is wrapped around the airway suddenly tightens, and then you have narrowing of the airway, even more narrowing of the airway. And so the affected individual will experience chest tightness and difficulty getting air in and out of the lungs, a whistling sound, which is the wheezing, and chest tightness. And one of the major drivers of asthma is allergies in a majority of children and adults. There are other triggers as well, but allergies play a key role. And finally, the last definition, anaphylaxis is an allergic reaction that's happening throughout the entire body, so that you have those mast cells are releasing their contents in the skin, the lungs, the gastrointestinal system, the circulatory system, and the nervous system, and you get this array of symptoms, and of course it can be life-threatening or fatal. The most common causes of anaphylaxis happen to be medications, foods, and stinging insects. So those are some definitions and some science, and we'll move on to some of the questions about allergies. Why do they exist? And it turns out that the IgE immunity system, with this explosion of chemical mediators that cause these dramatic symptoms, is really geared towards the protection against parasites. In areas that have parasitic diseases, there's a very low allergy incidence. And recently it was shown that some parasite proteins are very similar to pollen proteins, suggesting that allergies are really a case of mistaken identity. But this ability to fight parasites would be highly conserved in evolution and would account for why so many people would continue to have that genetic potential. So again, the specialized IgE response to the plant proteins that resemble parasites is probably what's happening. And so that accounts for, I think, why we have such a high incidence of allergies, 20 to 30%, but why are they getting worse? So food allergies increased 50% between 1997 and 2011, 1 in 13 children at this time. And the peanut allergy increase could be considered an epidemic because the incidence of peanut allergy quadrupled between 1997 and 2010 to greater than 2%. That's more than 1 in 50. And the asthma epidemic between 2001 and 2011 saw an asthma increase by 28%. And those of us in practice throughout these years clearly saw a change. There were so many more patients with peanut allergy than we had ever seen before, peanut and other allergies. And our patients very commonly said, what is going on? Why are we having all these allergies to foods? Nobody in my family has food allergies. Why is this? So there's some interesting theories. I'll say more about the hygiene hypothesis, but the idea is that that young children aren't getting enough stimulation from bacteria in their environment, microbes in their environment, and so the immune system is heading in the wrong direction because it needs to be modulated by these influences. And I'll come back to that. But climate change is clearly increasing the duration of the pollen seasons and the amount of pollen in the air. There's been a lot of interest in vitamin D because vitamin D is important in the immune system, and it is made generally in the body from the skin and sun exposure of the skin. And with all the putting on of sunscreen and limiting sun exposure, most of us have low vitamin D levels. And so that is one thought, but it's probably just one factor among many. Vaccines have been thought to maybe contribute because the children are not having as many illnesses, and so the immune system is freer to go off in an allergy direction, but that actually has been disproven, so vaccines are not an issue. Lifestyle changes. When children sit in front of a screen, they do not sigh as deeply as when they are actively engaged in something else, and that lack of deep sighing may influence how their lungs develop. And finally, infant feeding practices, which, as we will see, does really influence food allergies. So in the hygiene hypothesis, microbes matter. Fewer infections or fewer exposures to microbes, and by microbes I mean mostly bacteria in the environment, that the lack of this infection in early childhood may actually increase allergies. So some of the observations that led to that hypothesis is that with smaller family size, fewer siblings, there's more allergies because there's essentially less germ sharing. Not living on a farm predisposes to allergies. To some extent, not having a pet in the home makes the incidence of allergy higher, especially in the very early childhood and infancy. There was a study that looked at, in Scandinavia, the incidence of allergy in homes where they use an automatic dishwasher compared to washing dishes by hand, and it's thought that and there was a much higher incidence of allergy where the automatic dishwasher was used because it sterilized the dishes. And it's also thought that it's not just any germs in the home, but the oral germs that the parents give to the children are important to establish their, the new term for it is their microbiome of all the the bacteria in their bodies. And there was even another study suggesting that parents who pick a pacifier up off the floor and put it in their mouth and then hand it to their baby, those children have less allergies than parents that don't do that. And all of this may be an argument for probiotics, which of course are very popular to talk about these days, but there are many different types of probiotics, and they are being used to some extent, but it's not ready for general recommendation at this time. So feeding practices. And what happened towards the end of the 20th century was that there was a trend towards delaying introduction of solid foods for infants. So that in the 1960s, infants were often given solids before 4 months of age. And then by the late 1990s, the Academy of Pediatrics said no solid foods until after 6 months. And this kind of correlated with the push for breastfeeding and wanting to get the infants to get most of their nutrition through this preferred pathway through breastfeeding. And then the physicians that make such recommendations then became concerned about allergies, and so they recommended that by 2000, they recommended no milk until 12 months of age, delay egg until 24 months of age, and peanut at 36 months of age, which is quite a bit later than had been before. And the idea was that there was a window, that the infant gut was leaky, and that leakiness permitted proteins to escape into the system, and if you could bypass this window and wait till the child was older, they would not become allergic to these foods. So I just wanted to share one study with you because it is truly kind of an epic study, and it came out last year, and it's called the LEAP study. You've probably read all about it. It's an acronym for Learning Early About Peanut Allergy. And it started with the observation in a paper in 2008 by Dutoit, who is one of the authors of the LEAP study, that Israeli children in Great Britain or the UK had a much higher incidence of peanut allergy than Israeli children in Israel. And they looked to see what the difference was, and the author realized that the children in Israel were eating peanut at a much younger age. And the reason they were is that they had these snacks, which are shown in the slide, called Bomba snacks, which are those nice, soft, like Cheetos, those corn Cheetos that are dusted with peanut. There's no cheese on it, but there's peanut in them. And the babies would just chew on them, and they would get soft, and they would swallow them. And they were routinely given very young in infancy. And so they wanted to see if they could change the incidence of peanut allergy by giving early feedings of peanut. And the results were so striking that they had to stop the study and start publishing the results to the world so that everybody would know about prevention of peanut. So what they did is they took 4 to 11-month-old babies that already looked like they were headed for major allergies. They had either severe eczema or they had egg allergy or both. And they were tested, and if their tests were too strongly positive, they were disqualified because nobody wanted to give them peanut. But if they had a mild positive or if they had no positive at all, they were given peanut 3 times a week, a teaspoon of peanut butter 3 times a week mixed with something, baby cereal or whatever. They gave some Bomba snacks, and I think it's quite a few of those little curly things, but I think it was like 21 per dose or something like that. But they did it either way. They also did. There were some other ways that they did. Some used peanut soup. There were different ways they did. But what they were looking at as a result was peanut allergy at 5 years of age, and they found that in the people that really followed the protocol, there was almost 100% prevention. Not quite, maybe 80 to 100%, but it was so striking that they immediately stopped the study and started convening committees to put out new recommendations. So the children that may have allergies probably need some evaluation before they start peanut because they might already have allergies. It's amazing how many have allergies even when they're 2 months old already. And we think we can tell the difference and do this safely. But there were some that were on their way, like already had a positive skin test to peanut, and they were able to be prevented from going on to have peanut allergy. So it was just really kind of exciting to think you could stop that process in its tracks. And so at the bottom of this slide, the rationale that delaying exposure may protect against allergy is wrong. It's wrong. And this notion that early feeding will protect against allergy is really gaining traction because we are understanding more and more that it's about how you're first exposed to these substances that may determine whether or not you become allergic. So that if your first exposure is through the skin, say you're a child with eczema, you are much more likely to have allergies than if your first exposure is oral. So the oral exposure will help promote tolerance. So some of the old advice, delaying introduction of peanut eggs is probably not a good idea. Earlier exposure is better. Rather than completely avoiding all animals, pet exposure in early infancy seems to be helpful. And daycare seems to be helpful, these minor infections that children get in daycare. And the reason I put this slide in here is because we literally used to give this advice to patients to have no dog, to delay all these feedings, and to not use daycare. I didn't give all that advice. I gave some of those pieces of advice. So moving on to the hows. So of course I'm biased, but I'd like to suggest that it may be a good idea to have an allergy evaluation if you're suffering from allergies, because knowledge is power. Understanding what you're allergic to can help you to target your efforts to avoid the things that you're allergic to. And even though there are so many medications over the counter now, it's sometimes really helpful to have the advice of someone that is has been using them and knows them all. So for an allergy evaluation, the history really is the most important part of it because it establishes the relevance of all the other pieces of information. And the physical examination then helps to identify all the body systems that are affected by the allergy. I want to say a word that some people are doing a lot of screening for food allergies with blood tests, and without the history and the physical, you really just have no idea how to interpret the data. It's all you have to. You're always having to take these pieces of information and correlate them with real life, because if somebody has a positive and they're eating that food every day, they're tolerant and they should not stop eating that unless there's some other symptom going on that you're trying to fix, because they may lose their tolerance. So it can be fraught with peril to do random testing. But we do a lot of allergy skin testing in the office, and what we do is take advantage of the fact that we have those loaded mast cells in our skin just ready to give us a little hive if we expose it to what we're trying to test for. So we press, we first load these little testing heads with the droplets of what we want to test. We press them onto the skin so that the skin is penetrated slightly, just enough for the allergy cells to be exposed, and then we will get, we'll see what kind of reaction we get. And we have extracts for the pollens and the molds and the dust mites animals, and we have extracts for a lot of foods. And sometimes we use fresh fruits and vegetables or sauces or the barbecue sauce from a restaurant that might have caused a reaction. We can test with virtually anything to see what someone may be allergic to. And this is a person who has a number of positives. Each one of those little hives is a specific test, and we have it coded which one is which. There's some other types of allergy testing. Often they're not done the first time that you come in. There's patch testing to try to find out if you're sensitive to hair dye or nickel or fragrance or other substances. Those go on and stay on for 48 hours before they're taken off and read. And then those have a whole handout for each individual one that that you'll be given if you have a positive, and it'll tell you everything that substance is in. So that's good if you're having more, not this type of allergy, but more contact rashes. And then we do a lot of food and drug challenges. For an asthma evaluation, it's really similar to the allergy evaluation because of the connection between allergies and asthma, but we will often do a chest radiograph, pulmonary function test to measure the flow through the airways, and we have some special tests that will help us assess whether somebody has asthma. If when they come to the office, the airways seem to be wide open, but they're very, we can assess how twitchy the airways are, how sensitive they are to stimulants. Those are called provocation tests, and those are scheduled, but they're very helpful as well. And we're always mindful of things such as acid reflux and sinus disease because they can make asthma worse. So once allergies are diagnosed, we usually advise avoidance, indoor allergens, outdoor allergens, and there's a number of things that can be done. There's filters, keeping windows closed, washing in hot water to avoid dust mites, and avoiding stinging insects. We usually recommend try not to smell like a flower or look like a flower with fragrance and that sort of thing, and that can be pretty helpful. I want to say a word about food avoidance because, as I was saying before, there can be a lot of false positive with foods. Interestingly, we think that the food testing is great if it's negative because it has a 95% sensitivity. If it's negative, it's 95% likely that you do not have a food. So it is useful for checking it off your list if you're worried if a food could be a problem. We think this test is pretty powerful. Now, the positives are not, it's not 95% certain that you have a food allergy if you have a positive. It's maybe 25, 30, 40% possible. And so we always have to correlate those results with real life. And sometimes we do food challenges. Sometimes we do elimination of things from the diet, like say you had stomach trouble and you had a positive, you could take it out of the diet for a few weeks and see if the symptoms get better, and then if you wanted to, you could add them back. For some allergies, if they were severe enough and you identified a positive, you would just say, not worth it, not going to even look at that. A word about treatment, well, a few words about treatment. So oral antihistamines are probably familiar to most all of you. Things such as Benadryl, Zyrtec, Allegra, Claritin, and they block the effects of histamine, which is good and bad. Histamine is a major chemical mediator of allergies, but it's not the only one. And so they are not very good for congestion. They're not very good. They're sometimes not that great for they're not that great for coughing typically, and they don't typically have an effect on asthma. They may a little, but not typically. Nasal antihistamines such as Astelin or Patanase also block the effects of histamine, but they actually really are good for congestion, and they are absorbed somewhat, so they can be useful. And nasal steroids we're all familiar with because now they're all over the counter, but that would be Flonase and Nasacort and Rhinocort, which are now available over the counter. These are very really absorbed, but it's better if they're not absorbed because of potential for side effects. But they block the effects of many of the other allergy mediators, and that's why they're useful in conjunction with the antihistamines, because they will be a lot better for preventing sinus disease and helping with congestion. And then, of course, there are a number of topical eye preparations that will either act as an antihistamine or stabilize some mast cells so that they don't release their chemicals in the eyes. And all of those that I just mentioned are available over the counter now. So that's kind of newer in the last few years. But, you know, for all those years, they were prescription, and we were carefully choosing which one would be best for which patient. So I think it must be a little bit confusing because I think there's always the assumption that they're totally safe if they're over the counter, and they're also equivalent to one another. But and then oral anti-leukotrienes, that would be Singulair and Accolate, which can be really helpful for congestion, sinus symptoms with respect to allergies. They are specifically indicated for allergies, even though they were originally developed for asthma. And then for asthma, I'll mention a few medications. A lot of big words on this slide, but the bronchodilators are, there's really just one short-acting bronchodilator, and that's albuterol, which opens up the airways by relaxing the muscle. Anti-leukotrienes I just mentioned, they are helpful for mild cases of asthma, but for some people they're amazing and really help their sinus and nasal symptoms as well as their asthma. I've seen patients get off inhaled steroids once these came on the market many years ago. The most effective relievers of allergic inflammation of the airways are the inhaled corticosteroids, Flovent, Qvar, Asnex. There's quite a number of them. They're extremely effective if used properly and strategically, and there are some good strategies to use. They do take hours to start working, but they do work fairly quickly. And then, of course, there's combinations of the inhaled corticosteroids and some longer-acting bronchodilators that have become very popular and really are effective for the patients with more severe asthma who typically need a bronchodilator multiple times a day, and that would be like Advair, Dulera, and so on. A word about immunotherapy. Conventional immunotherapy is typical allergy shots. It's been around forever. It's interesting because remember when I was talking about IgE, how small it, what a small presence it has in the body. It's very, its concentration is extremely small. So allergy testing and immunotherapy went on for many, many years before IgE was even understood. And it wasn't discovered until 1967 what the actual IgE molecule was. But so conventional immunotherapy has been going on forever, and it's just the basic. They take purified plant extracts and inject them subcutaneously, and with that consistent high dose, with good access to the immune system, you literally become immune to the things that you're allergic to in a way that natural exposure doesn't, because it's a surface exposure and it's not enough, and it's not there's not a good enough access to the immune system. In fact, the natural exposure makes your allergies worse. Each season you get a rise in your allergies. And so we have we base our immunotherapy on the test results, and we have pollens and molds and animal danders and so forth. We don't do it for foods. And usually there's a time that you can stop. You do it after 3 to 5 years and you can stop. And it's highly effective for several types of allergies, pollens, mite, and cat, and it's also highly effective for asthma, hay fever, and sinus disease. I wanted to mention sublingual immunotherapy, which I think is really exciting. It just was approved a year or two ago. It is a method by which you use grass allergen or ragweed allergen as tablets under the tongue, and it dissolves there, and you do it every day. You have to start 12 weeks prior to the allergy season, but you can use them year-round. And actually, if you use it year-round for a few years, it'll actually, the results will, the effects will stay in your system for at least another year after you stop. The only problem is most people are sensitized to many different things. They want their cat in there. They want the molds in there. The oak pollen. Oak pollen is so huge here. But for grass and ragweed, it's another therapy, and it's very safe, and people do it at home. So that's definitely a newcomer to the horizon. You've probably read about these places that are doing induction of oral tolerance for peanut allergy and other foods. This is, and I think there are some people doing it in St. Louis. But the people that are doing the research emphasize it's not ready for prime time because everybody's concerned about the possibility of side effects, like perhaps esophageal symptoms if you actually are eating this food over and over again to get tolerance if you're already allergic. This isn't for primary prevention. This is like trying to cure peanut allergy. But they are developing patches that will deliver peanut to the system, and they're thinking that will be able to induce tolerance in people that are already allergic to peanut, and then that might be available for other foods as well. So that will be very exciting because you wouldn't expect there to be any side effects from that. So, so we've gone through some of the basic information about allergies, and then some of the recent questions, well, some of the interesting questions, I think, and some of the recent data, and finally how to manage allergies. A word about prevention. I would just leave you with this thought that clearly what we know today is that avoidance is not the same as prevention. And prevention strategies may have to take place in a very young child, but their immune systems exist not in a vacuum, but in connection to the microbial environment around them, and their immune systems need to be educated by a number of different factors to end up with tolerance instead of allergy. But if it could be worked out, there may be multiple food allergies that can be prevented. There was a follow-up study to the LEAP study looking at even younger children, and the results were really promising for peanut and egg and milk. even as early as 2 weeks of age in babies. And if it can be worked out for the foods, it's possible it could be worked out for other allergies as well, and we could prevent them in the future. So I wanted to leave time for some questions. If anybody has any. Yes.
Environmental. I mean, I'm trying to think. At 1 or 2 weeks, how do your system just how pretty much you're born with, right? So it almost seems to me like you're instead of environmental, I have environmental, over the cat.
Well, sure. I mean, it has to be genetic because a lot of people, no matter what their environment, they will not have allergies. And so, so the recommendations, like, are you talking about like the feeding recommendations for babies?
Yeah, I was just thinking that if the age you determine somebody's allergic, I think my allergy changed until I was older.
Oh, well. Yeah, it'll be trickier with those ones because you're right. Children grow into their allergies and they peak statistically around age 15 or so, and then they usually plateau and stay throughout the adult life. So the that would be hard. You wouldn't really be able to necessarily know that in that age group. But there are a lot. I mean, the food allergies typically present at a very young age, and if you're not allergic to peanut at age 5 or even age 3, if you've been exposed, you're probably not going to be. But most of the kids that you would, most of the kids that in the general population wouldn't really be at high risk, but you'd probably just feed them early just to be sure that that you don't go down that path. And again, this just looked at the kids that were very high risk, or considered to be at much higher risk than the average child. But that risk would be conferred by genetics. But the same genes didn't produce food allergies to the degree that it did between 1997 and now. So it's a definitely complex situation. You're absolutely right. Well, there's other factors with asthma too, because if you get a certain type of viral, there's a whole science of all the things that impact asthma. A virus at a window of time can skew the immune system in a certain direction. RSV is one of the viruses that's really been studied a lot. So it is really complex. And she did outgrow. Oh, that's wonderful. And does she have allergies? Okay. If you have asthma as an infant and you don't have allergies, it may be other factors, and you may outgrow it more, and you may be more likely to outgrow it than if you have a lot of allergies, because those allergies will kick in more and more as you get older and older, and may help your asthma to persist. But that's a nice story. That's good. I think peanut allergy is just so common, and the observation was made for peanut because they feed children in Israel peanuts so young. I think everyone can start looking at the other ones. Like, should we be giving people babies Nutella so they don't become allergic to hazelnut? Do we need to? And is it worth it? But I think it has to do with how common it is, whether it's worth it to actually have a preventive. But those nuts can be pretty allergenic, as they call it, as well. There's some pretty severe reactions to all those tree nuts. It's just that peanut butter is introduced. It's around in households, and it's in part its molecular structure. It's just highly likely to cause an allergic reaction in some people, or cause sensitization in some people, and then you have an allergic reaction and subsequent exposure. So. All of a sudden developed something very close to anaphylactic while handling shrimp and shellfish. I guess
it was an earlier exposure that triggered the antibody and then this was secondary reaction? Why? I mean, you have anything in childhood and have shrimp and other shellfish.
And we do see that shellfish allergy showing up later in life when they're a little bit older, and it does presume that there's been some sort of exposure, and then you make the allergy antibodies, and then your allergy cells are ready to go. And does he eat shellfish?
He had eaten some of them, but he had been preparing them all day, and then was able to take some home. And he went home and had some of the prepared food and just rushed him to the hospital, unable to breathe properly and breaking out in hives and red rash everywhere.
Yeah.
So that is something that, you know, he didn't have in childhood, but then got as an adult.
Correct.
So I guess this speaks to the fact that your body's constantly changing, and where she outgrew her, you know, my son developed it as an adult.
Right. And there may be, it might get figured out as sometime that if you're at risk for it, and how do you know if you're at risk? Maybe if you were, like say for example, somebody is eating shrimp and they're 5 years old, you know, maybe we'll say, be sure you eat shrimp every few weeks. You know, maybe there's a way that you maintain your tolerance so that you don't switch later or something, but there's just not a lot of information about that. But it's really intriguing. Can you interrupt that march towards an allergy to something, whatever it is, shrimp or whatever?
All this gluten-free movement that's going on, where everybody thinks it's related to a gluten allergy, is that really what people are experiencing as a true allergy? I thought celiac disease is the only thing that's a true allergy.
It's a true allergy in that the immune system is involved in celiac disease in making antibodies to gliadin, which is part of gluten. It's not an allergy like this, where there is these explosive reactions to immediately to contact. It's more systematic damage to the intestinal lining or the skin or wherever you're having your celiac symptoms related to the immune reaction to it, to gluten. And so it is separate. It is separate from this, and it's not tested for the same way. And you know, some people feel that it is true. I will say this: it is true that until there was an easy test for celiac, it was missed. And so a lot of the increase in diagnosis of celiac disease is the availability of a good test that's easy. It's a blood test. It used to be tremendously difficult to diagnose celiac disease. It required intestinal biopsies, repeated intestinal biopsies, changing the diet. It was really difficult. And so nobody knew what the true face of celiac disease was until they started having an easy test. And some people just have a rash, and some people have all kinds of different symptoms. So it was really necessary and beneficial that all these cases were discovered. But some people suspect that it's, you know, that there are a lot of people who do not test allergic to celiac. I mean, that the celiac test is negative, but they feel better if they stay off of gluten, or some symptom is better, their arthritis feels better. I don't think we understand that very well. I don't think we know the mechanism for that. What? I think that's what people think. I haven't seen the science, you know, the hard scientific data, but you know, there's so many people that feel that way. I think it needs to be investigated. But yes. Your what is high? IgE level. Your IgE level is really high. So I was told that it's tolerated. Yes, and in fact, I think it is that there's a slide missing, because there's Xolair, which is directed at IgE, and there's also now Nucala, which is directed at which we have a monoclonal antibody directed at IL-5, interleukin 5. Xolair is a way to modify the immune system, so it is a type of immunotherapy. It's a monoclonal antibody, meaning that it's a type of antibody that's developed that's specific for a part of the IgE molecule that takes it out of circulation And so you get these injections at 2 to 4 week intervals depending on how high your IgE level is, and then your IgE levels, your IgE immediately becomes inactivated. Your levels actually go up, but the IgE is no longer able to cause all these allergic reactions, and helps the asthma to be better. It's actually a very effective therapy, and I think it's been around long enough that it's it's been around for many years now, and there's really not been any scary side effects, I don't think. So I think it's a reasonable choice if the other medications aren't working.
Oh, well, honey, I'm a little dirty.
10-second rule. I know. It's really interesting. It's so humbling that there was so much bad advice given for so long. It's really. Is your mother still living?
No.
Oh, I wish you could have told her about that.
Mom said that for her 7 years.
Oh, sorry. Yeah, our mothers.
I grew up in the 50s, so it was quite different back then. We did blame her. Yeah.
I know. We didn't worry about the dogs. We didn't worry about the cats. So anymore, you want to be born by vaginal delivery, you want your mother not to have antibiotics, you want to have a dog in the home when you want to breastfeed. Those are all things that are supposed to be helpful. But then that EAT study I was telling you about briefly that that looked at feeding very young children, it looks as though it's probably going to be helpful for infants to get some cow's milk formula in the first 2 weeks of life to prevent cow's milk allergy. And think about how guilty everybody feels if they're not nursing successfully and their baby has to get supplements with formula. I mean, we all felt so horrible when that happened and are so upset that our babies got formula, and probably it wasn't a bad thing. It's like everything is changing. It's so interesting. And so the people that say there's only one right way to do things and no formula in the nursery, not so much, it's all different now. So we'll see. There are some soy. There is a fair amount of soy allergy already, but well, I think Matt told me to be finished by 1:15. So thank you all for staying. I appreciate it. Thank you.